Sarah, thanks so much for doing this chat really quick with us. As a part of Blood Cancer Awareness Month, I thought this would be a great opportunity for us to learn a little bit more about hereditary heme malignancies, because this is certainly a new topic for a lot of referring providers to be thinking about as they're sending over patients to us, but also for a lot of genetic counselors as well. So I think this would be a really great conversation for them to listen to. I thought one really helpful place to start is just in general, how do patients end up in a leukemia genetics clinic, or if they're even being seen for something like hereditary lymphoma, if that's something ever of concern?
Yeah, so it's a great question, and I think kind of institution specific at this point. There are very few hospitals and clinics that I'm aware of that have a specifically dedicated clinic for genetic counseling for leukemia patients, but most of them are getting referred to local institutional resources for kind of a couple of reasons, usually age, if we think about other types of cancers and age-based referral criteria. So typically people will get flagged for referral to genetics if they're diagnosed with myelodysplastic syndrome or acute myeloid leukemia under the age of 50. That's now, we finally got an age. For a long time. We didn't have NCCN guidelines or a really hard and fast rule for young age of diagnosis, but usually diagnosed under the age of 50, or individuals who have somatic profiling that shows a concerning variant that could be in a germline predisposition gene, some cytogenetic abnormalities that can link with inherited blood cancers, or like other patients with solid tumors, a family history. Blood cancers are rare. And so, unlike seeing a family history of solid tumors, which we kind of expect someone will have a family history of some type of cancer, in people who have solid tumors, if we find a family history of blood cancers and somebody who also has a blood cancer, that's usually a sign that a genetic workup is indicated.
So, definitely heard about cytogenetic changes that you might pick up on a bone marrow biopsy and family history and age. And I think it's really helpful to know that there are established NCCN guidelines out there that providers can turn to. Um, any other major red flags that you, when you're consulting with the patient, might think about, even if it's not necessarily related to their specific cancer, but maybe other symptoms or other health issues that you might notice in the patient and their family?
Yeah, that's a great question. So I think in cancer genetics, we're used to taking a pretty cancer focused family history, but a lot, I would venture to say many of the inherited predispositions that can cause blood cancers have non-cancer symptoms. And that can be things like low blood counts, so thrombocytopenia, which is a low platelet count, or a family history or personal history of recurrent infections, especially opportunistic infections that require IV antibiotics, or recurrent infections, a lowered immune system, as well as things like pulmonary fibrosis, non-alcoholic hepatic cirrhosis or liver cirrhosis, warts, premature gray hair, things that we wouldn't necessarily be taking a family history of if we didn't know to look for them. So in people who have a personal history of blood cancers, I think a great question is usually about whether they've had blood cancers before or low blood counts previously in their life, a family history of low blood counts in their parents or siblings, and the symptoms of those things, nosebleeds, heavy periods for low platelet count, recurrent infections for low white count, being diagnosed with anemia, especially if it's not iron deficient anemia. So those types of non-cancer histories in the patient and the family can be really helpful too.
Yeah, definitely. I kind of I'm thinking about this as someone who is not so much in leukemia space. It sounds like a lot of these non-cancer related features that you can notice are pretty common to be seen in the general population. Pretty common to have people in your family who have, recurrent warts or nosebleeds or, recurrent infections. So I'm curious, how do you think about that, as the leukemia genetics expert talking to patients of, okay, and I'm noticing a couple of soft markers, but it overall looks pretty normal versus, ooh, this is kind of sticking out to me as something that could be concerning.
Yeah, that's a good question. I would say I'm not exactly sure how common these things are to come up in a family history unless we elicit them,
Yeah.
as genetic counselors. But I think patterns I would look for would be these types of clustering of these non-specific or soft signs on the same side of the family. So if you have a young person with um, acute myeloid leukemia, for example, and they had low platelets for many years, if not their whole life before they were diagnosed, and they report a history in a parent who bruises easily. Let's say it's mom, and she also had heavy periods. And then maybe on her side of the family, they bruise easily. There was maybe a stroke related to a bleed or something like that. Could all be pretty suggestive that maybe those soft signs are actually the result of
Mhm.
thrombocytopenia. But what's interesting about patients with blood cancers is that for the most part, they become very knowledgeable about their blood counts, and they know what they're called, and they know when they're low, and they know what the symptoms of them are when they're low. And so sometimes they have more insight into whether their family members actually had a regular nosebleed, like allergy related, versus my mom also bruised easily, had low platelet counts, and had a nose and had issues with heavy nosebleeds. So I think a lot of it comes down to just sort of our gut risk assessment,
Mhm.
tracking on the side of the family, asking specific questions. And, sometimes if there's no like real family history, or it's on both sides or the other side, I usually would say, well, these things can be related, but I'm not seeing a strong pattern here, versus where it looks like maybe, especially with telomerology disorders, which we might
Mhm.
talk about later, premature graying, abnormal nails, liver cirrhosis or pulmonary fibrosis on the same side of the family or in close relatives would be something that I would look at pretty closely.
Yeah, yeah, definitely. Which is why I think kind of having that conversation with someone in genetics is probably really helpful because they're going to be able to pick up on a lot of those soft markers that are clustering in a family where maybe a non-genetics provider would, think, oh, this is, a normal thing that you might see as a health issue
Yeah, or that
relative.
since those things are all on the surface unrelated,
Mhm.
especially if
Yeah.
there's squamous cell carcinomas in a family too, where you suspect telomerology disorder, it's difficult for a non-genetics provider to put so many apparently unrelated things together, right? Myelodysplastic syndrome and AML, premature graying, dysplastic
Mhm.
nails, pulmonary fibrosis,
Mhm.
oral squamous cell carcinoma.
Right.
Like there's not much that tells somebody to put those things together if you don't know what you're kind of looking for.
Definitely. Definitely. So I feel like from having conversations with people about hereditary heme malignancies, there may be a misconception that it's quite rare or very rare compared to other hereditary cancer syndromes for there to be something genetic going on. So can you kind of tell us about how to think about the frequency in general of hereditary heme malignancies compared to that, you know, typical 5 to 10% of genetic conditions that we'll talk about for cancers?
Yeah, I think that is a common misconception, and one that even I had early in my career. I think most of us were trained, certainly physicians were trained, genetic counselors were trained up until very recently that leukemias were sporadic. And so it's been very hard to overcome, that sort of like longevity of not thinking of these disorders as hereditary. So that's one thing that's contributed to that sort of misconception. But the other thing is that evidence is pretty hard to come by, in terms of what is the true frequency of an inherited predispositions, because we can't easily do, a series of unselected patients with
Right.
blood cancers because their blood's hard to test. We need a germline sample, we need skin biopsies.
Oh,
So
see.
it's taken a long time for us to start to test enough people and gather enough data that's a little less subject to referral bias to actually really get to the bottom of that. And I think the answer is going to be different for each type of leukemia. So even though leukemia or hematopoietic malignancy is this big sort of overarching class of blood cancers. We use those terms interchangeably. Underneath that, there's, somewhere between 10 and 20 subtypes of specific types of leukemia that have varying amount or, varying potential to be hereditary.
Mhm.
So There have been some recent studies looking at unselected patients with AML, acute myeloid leukemia, which myeloid leukemias are in general thought to be more hereditary than other types of leukemia. And for example, we think that somewhere between somewhere around 2% of unselected patients with AML will have a hereditary cause, like specifically DDX41, which appears to be maybe the most common genetic predisposition to AML, maybe in about 2% of cases. On the other hand, you can really drill down, for example, myelodysplastic syndrome in children and young adults, especially adolescents with a very specific profile of their MDS, including monosomy 7, up to 75% of those patients will have a germline predisposition. So it is a wide range from basically 3 and 4, 75% of certain subtypes in specific cases. But in general, I think roughly the field sort of accepts that somewhere around 5 to 10% of MDS and AML, those specific myeloid malignancies, are hereditary. I think for ALL, the accepted number is possibly somewhere around 4 to 5% for acute lymphoblastic leukemia. And if you just sort of take a high level sort of view from the clouds, I think we're looking at somewhere between 4 to 18% of children and adults diagnosed with any type of blood cancer will have a genetic predisposition. And I really think in the next 5 to 10 years, we'll have a much, much better idea of what that is as more people are getting interested in this and are starting to do more sort of unselected testing, kind of testing all comers. NCCN guidelines recent recommendation to test everyone with MDS might help to learn more about that specific population. So it's emerging, but I think it's similar to possibly even more hereditary in some cases than other solid tumors that we think of.
Yeah, definitely. I think that was a really great summary as well of kind of looking at it globally, but also within the heme malignancies, how they compare. And I hadn't actually thought about the logistics of doing germline testing for heme malignancies being a barrier and kind of contributing as well to the ascertainment bias because, we certainly have less time of testing for heme malignancies compared to something like breast or ovarian cancer, but also testing for those cancers because they're solid tumors is much more logistically feasible. So I think that's a really interesting point there about
and that's
how we can get that data. Yeah.
That's how we have, studies that look at thousands and thousands of people with breast cancer, because you can take a blood sample from every person who walks into your clinic if they are willing, and do a genetic test. But I think we are still, we proudly published out of MD Anderson several years ago that our even, back in circa 2015, we weren't even getting enough family history on patients with leukemia to know if they even qualified to be referred to genetic counseling. So considering, in the past 9-10 years, we're overcoming that really early days. Do we even have enough information to refer patients to genetics? Which makes that sort of like unselected, we should be testing everyone with leukemia or specific subtypes of leukemia, pretty challenging. So it's going to take a lot of collaboration of people's sort of small unselected groups that they end up testing to put together to, outside of biobanks. The biobank recently, a biobank study on DDX41 showed an incredibly high carrier frequency in the general population of about 1 in 130. And so the question is, that's not equating to how many people develop MDS and AML. So I think there is a lot of room to be done there.
So Sarah, earlier we were talking a little bit about the different red flags that makes us a little bit more suspicious for a hereditary cause for heme malignancy, and you mentioned cytogenetic changes. I was hoping you could talk about certain either cytogenetic changes or somatic findings that we can see in bone marrow biopsy that actually reassures us. So I think a lot of people are familiar with BCR-ABL fusion and CML. That's typically something that is reassuring from the genetic side. So I'm curious if you can give us a little bit more insight on other things that we can see in a pathology from bone marrow that's also reassuring.
Yeah, so there are a couple subtypes of AML that are almost never hereditary. One subtype is called core binding factor AML, and it's sort of defined by two specific cytogenetic findings. One is a translocation of 821, and the second is inversion 16. They're rarely seen together, but like one or those others would sort of indicate that the type of leukemia is core binding factor. And core binding factor typically occurs in young people and also has a fantastic prognosis. And so sometimes if you're sort of referring patients for genetics based on age-based criteria, you're going to capture those patients with core binding factor AML, but they almost never have an inherited predisposition. The same goes for a subtype of AML called acute promyelocytic AML or promyelocytic leukemia, APL, which is characterized by a gene fusion called PML-RA-RA. So that's caused by a similar sort of translocation to fusion like BCR-ABL, but the two genes involved are PML and RA-RA. And so the presence of a PML-RA-RA fusion on their pathology would indicate APL is the subtype. APL is also almost never hereditary and occurs almost exclusively in young people. So again, those are patients who might meet an age-based criteria to be referred for genetics, but will have an incredibly low chance of having an inherited disorder. In patients with aplastic anemia, you can check for what we call a PNH clone, which is paroxysmal nocturnal hemoglobinuria. Taken some practice to say that. So a positive PNH clone has been shown to be almost mutually exclusive from an inherited cause. So similar to how you think about like BRAF and MLH1 loss in patients with colorectal cancer, if you're screening for Lynch syndrome, a positive PNH clone in someone with aplastic anemia almost certainly excludes a germline predisposition. So those are pretty good signs to look for that would reduce the risk.
Right. And it sounds like a lot of these things are a pretty standard part of the workup, or it's pretty common for those things to be assessed for, not necessarily something a provider would have to specifically ask to be done to rule out a genetic cause or hereditary cause.
Exactly, exactly. So cytogenetics are done on anybody who has a bone marrow suspected to have a hematologic malignancy. And PNH is pretty routinely tested, especially in patients who are sort of undergoing the diagnostic workup to see if they have aplastic anemia versus other causes of pancytopenia. But PNH is one that I've noticed is sometimes missing that can be ordered to kind of help as part of the workup for aplastic anemia, but it's typically done up front or close to or around diagnosis, and you can look to see if they had a positive PNH clone or not.
Got it. We had been talking a little bit as well, Sarah, about germline testing and how a lot of times we'll use skin punch samples for patients who have an active leukemia. Can you tell us a little bit about other types of tests that you might think about as part of the genetics workup outside of germline testing that's also important to keep in mind?
Yeah, so especially when it comes to young people with myeloid malignancies, the differential diagnosis for those patients is really broad. So it ranges, of course, from like single gene predispositions, like RUNX1, familial platelet disorder, DDX41, GABA2 deficiency, which would be identified on like a germline panel, like we were talking about on skin fibroblasts. But we also have quite a long list of inherited bone marrow failure syndromes that can present as MDS or AML in young folks. And two of the most common of those are Fanconi anemia and dyskeratosis congenita. That's rather the old term. Now we're moving more towards short telomere syndrome or telomere biology disorder. And for both of those, there are biochemical tests that can be fairly diagnostic, if not the gold standard, that are not done on fibroblasts, with some exceptions, and are not a germline panel. And so one of those, for example, is a DEV assay or chromosome breakage study that's used for Fanconi anemia. I'll plug here that people with Fanconi anemia and leukemia predispositions and inborn errors of immunity and probably other syndromes can undergo something called somatic reversion, where their bone marrow sort of removes the second allele or does some other song and dance to sort of reduce their cellular, to reduce the clone or some cells in their bone marrow to having only one mutation. So I say that because in patients with Fanconi anemia, if they've undergone somatic reversion, if their bone marrow is kicked out a second allele or acquired uniparental disomy or some other thing, they will not be picked up as Fanconi anemia on a chromosome breakage study in blood because their blood status will be a carrier. It's crazy. And so sometimes you want to actually do a chromosome breakage study on a skin biopsy in that case, if you suspect that's occurred. But otherwise, you can do a chromosome breakage study to evaluate for Fanconi anemia, and perhaps even more importantly, in patients suspected to possibly have telomere biology disorders, is to do a telomere length test, which is done by FlowFish. And that's almost always, if not to my knowledge, completely done on blood samples in people, even with active leukemias. It's particularly important because even though we know about 12 genes that can cause telomere biology disorders in every inheritance pattern, we can only identify a germline mutation in about 40 to 50% of cases. So there's a pretty significant number of people who might have short telomeres underlying their hematologic malignancy or their family history that will be missed on genetic testing alone.
Got it. And kind of while we're in this space of thinking about testing, can you give us a really quick summary of instances where blood or saliva can be used for germline testing, and when we really want to avoid using those sample types because of possible somatic variants from the heme malignancy or because of prior therapy?
Yeah, so the concern is not just possible somatic mutations, of course, but also cytogenetics are usually pretty wonky in patients with blood cancers, and they can have loss of certain alleles too. So sometimes you can lose an allele that's got a germline mutation on it, and so a blood test would actually be a false negative in those patients. And false negatives are scary because how do you know which one is false? Whereas on somatic, false positives can be a little easier to figure out because you can repeat the test on a skin biopsy. But that being said, in general, patients who have an active acute leukemia, acute myeloid or acute lymphoid leukemia, patients who have MDS, and patients who have active CML or CLL, so chronic myelogenous leukemia or chronic lymphocytic leukemia, almost exclusively need to have a skin punch biopsy or other non-germline tissue done at the time of testing. Now, patients who are in remission from those cancers, in CML, we'd be looking for what we call sort of a complete molecular response, or their BCR-ABL is undetectable. They can typically use blood or saliva. Patients who were treated with chemotherapy only for their acute leukemia and are now in remission, especially if they've been in remission for a while, like 1 year or more, is usually a pretty comfortable time that you could use a blood sample. The exceptions to that are for patients who've, of course, had stem cell transplants. So if a patient has had leukemia in the past and now they're fine, a good question is to ask if they had a stem cell transplant, because, of course, in those cases, you want to use a skin punch biopsy all of the time, 100%, no exceptions, because you'll be testing the donor's DNA if you use blood or saliva in those patients.
So, Sarah, just to kind of tie the bow with this really, really helpful conversation about this beast that is leukemia genetics, can you kind of talk us through some more common conditions that you might come across through germline testing, especially the ones that could impact treatment or therapy or management for patients and their family? I know you've mentioned DDX41, Fanconi, telomere biology disorder. So if there's anything more you want to share about the management side or treatment side of those conditions, plus others that maybe are really helpful for us to think about.
Yeah, sure. So, I mean, the number of germline predispositions is long and growing. So
Right.
we have now over 20-ish single gene predispositions and many inherited bone marrow failures and syndromes, and basically all of them have the potential to impact treatment and management almost in every case by stem cell transplant planning, whether that's the conditioning regimen. For many patients, those with inherited bone marrow failure syndromes typically need a reduced form of intensity conditioning for transplant. And in every case, DDX41, RUNX1, GATA2, inherited bone marrow failure syndromes for the donor selection in their family if they are going to proceed to hematopoietic cell transplant. So in all of these cases, germline testing can make sure that a relative who is a carrier of the condition, and by carrier, I mean affected, not a recessive carrier,
Right.
can really should be in every case excluded as a donor for a patient, except for circumstances in which there are no other options, and there are a lot of nuances there. But DDX41, for example, not only can you use that for transplant planning in terms of donor selection, but in some cases they might benefit from a treatment that's not typically used for patients with non-DDX41 related MDS and AML. In the same vein, for GATA2 deficiency, you can sometimes use that diagnosis to help indicate whether transplant is needed, especially if they only have the immune features, as well as family member testing. So actually, a better question is, can I think of a common genetic
Right.
syndrome that does not impact management and
Right.
treatment? The answer to that is no. So I think it's really amazing how much germline genetics impacts the care and treatment of patients with leukemia and their family members. I mean, more so than in many other solid tumor predispositions, simply based on the fact that medical treatment, their chemotherapy, whether they get radiation, their transplant conditioning, and their donor selection, whether that's a related donor or needing to use an unrelated donor, is intimately tied with whether there's a germline predisposition. And so I really hope that we start to see it more broadly adopted.
Yeah, definitely. Well, and I think that really emphasizes the need for us to get more comfortable with talking about germline testing for these patients and their families because of the impact that it has on therapy decisions. So, Sarah, thank you so much for giving us a really, really amazing summary of how to think through hereditary heme malignancies. And I am sure that when people listen to this, it's going to kind of start to get them more comfortable having those conversations with their patients. So thanks so much for your time.
Great. It flew by. There's so much more.
Yeah.